Hi, we're going to talk about endocrine control of growth here, and it's going to focus on the hormones that develop a normal human being into the complete adult stature. So this is the topic number, and my name's Derry Morgan. You can contact me at derrymorgan at rush.edu, and my lab is at 1245 Jelke. I respond best to emails, and I'm pretty quick with that, so that's the best way to contact me if you have any questions about this content. So what do we mean by growth? Well, growth is the organised addition of new tissue as occurs normally during development from infancy to adulthood, and it involves the lengthening of the skeleton, particularly the long bones of the legs and the vertebrae, but all the soft tissue, all the organs grow in proportion to the height of the skeleton that is predetermined by your genetics. And growth requires adequate nutrition to produce the building blocks required for the growth of your skeleton and your organs and your muscles as you develop fully to your adult stature. So this is a growth chart that shows both the height and the weight of an average human being from birth all the way up to their adult stature. And you'll notice in this there are two growth spurts. There's one shortly after you're born in the first year of life where you have this first elongation and a large increase in mass, and then you have a sort of more linear period before you hit puberty where you have a final growth spurt and you achieve your complete adult stature. And so the hormones that control these various growth periods are, I'm going to list here. And you have growth hormone and somatomedin. This is kind of the main hormone combination that dictates your growth throughout your life. And we'll talk about that extensively. Then we have thyroid hormone that synergizes with both these two. And in its absence, you have growth defects that I'll emphasize during this lecture. Cortisol is also involved in growth, as is insulin, but I'll only sort of touch on these in a smaller fashion, although I will highlight some of cortisol's effects around the body that you should be aware of. And then testosterone and estrogen that are very important for growth during puberty, and this also synergizes with growth hormone and somatomedin during this period to help you achieve your full adult stature. So this chart shows you the various stages of growth. We can think of them as being four types. You have fetal growth, then you have this growth spurt between 0 and 1 years. Then you have this linear period of growth between 1 and 12, and then you have puberty, which is split into two here, mainly to emphasize that puberty happens slightly earlier in females compared to males. Now this first column talks about the percentage of adult height achieved, and so when you're born you're about 30% of your complete adult stature, then you go up to about 45% of that in the first year of growth, then you reach about 85% of your full height and weight at 12 years, and then puberty brings you up to the full height. Now we'll notice then as we go through these columns the different time points, time frames where these hormones are most important. IGF is required throughout life, but after birth this is stimulated by growth hormone. Before birth the IGF is given by the mother, but it's required throughout all periods of growth because this is kind of what stimulates the target organs to grow. But as I said, growth hormone is required after birth in order to stimulate the release of IGF that then stimulates the growth. Thyroid hormone is required throughout all stages of life, but it's particularly important during this perinatal period, this period that's sort of 23 weeks after fertilization till about a year after birth. And if it's not around in significant quantities during this time, then the neuronal development is stunted, you get cretinism, and it's required as well during the other periods of growth, because in absence of it, then IGF doesn't function quite so well. And then you have the sex hormones that are required during puberty, and this then greatly increases your growth during this period by again making IGF work better. Puberty occurs earlier in females, and this is has consequences on the differences in height between males and females that I'll allude to later on. Insulin is required throughout your life, and this is mainly due to metabolic control of growth, because it's one of your main anabolic hormones. So we'll start then with growth hormone, and we'll talk a bit here about how the growth of the bones happens. You've seen this before, but just to go through it again, we have a younger bone here shown on the right, and then we have this sort of dotted line that is a superimposition over this older bone. And this is basically to show you how the bones grow. They grow longer, and they grow thicker, and they grow wider. And this is because new bone is placed down as cartilage here, and older bone is then taken away, and you get bone put down. So you have this sort of cycling, this modelling of bone being placed down as cartilage and the older bone being taken away, and this is due to the actions of osteoblasts that lay down the bone, and then osteoclasts take it away. And sex hormones have the effect of closing this epiphysis that then prevents further bone growth, and this is why you don't grow anymore after puberty. And this is also why men tend to grow taller than females, because they have a longer period for these long bones to elongate before puberty then comes, gives you a growth spurt, but it shuts off these epiphyses, so you have no more cartilage laid down, you have no more elongation of the bone. And this whole growth is stimulated by growth hormone through the effects of IGF-1, which is released from the liver, but it's also released from the bone plates and other target organs that are stimulated by growth hormone to release IGF and increase the number of receptors for IGF that then stimulates this growth I just talked about. It's worth remembering the control of growth hormone release from the hypothalamus pituitary target organ axis. In this case it's the liver and the bone. So the hypothalamus releases growth hormone releasing hormone that then stimulates the pituitary to release growth hormone that then affects the target organs to release somatomedin, or otherwise known as IGF. And you'll notice that these hormones that are released from the different places all feed back negatively on the different organs of this axis, so you have a large amount of feedback loops all over the place. Growth hormone releasing hormone will stimulate the inhibition of its own release. Sorry, I said that. So it will inhibit its own release. Growth hormone will also inhibit its own release from the hypothalamus via inhibiting the release of GHRH, and then somatomedin will also come back and inhibit the release of growth hormone, releasing hormone and growth hormone from both the hypothalamus and the pituitary. And this then gives the whole system a large amount of control through this negative feedback. Also notice what stimulates the production of growth hormone releasing hormone and thus growth hormone serotonin, dopamine, alpha-adrenaline, stress and sleep. These will stimulate the release of growth hormone, and then conversely, beta-adrenaline, high blood glucose, high free fatty acids, the well-fed state. This inhibits growth hormone release and thereby can affect growth. So this is growth hormone control simplified. Again, we have growth hormone releasing hormone, stimulating growth hormone release that works on the bone and the liver to stimulate IGF-1 that then stimulates growth via the bone. But then also growth hormone will stimulate somatostatin, which then inhibits its own release, and also IGF-1 will stimulate somatostatin release, which will also then inhibit the release of growth hormone from the pituitary. And there are therefore lots of feedback loops to keep a good control over this whole system. So this graph shows the overall effect of growth hormone, this figure rather, and growth hormone stimulates growth through the actions of IGF-1, but it also has specific effects on many organ systems, and in those places it stimulates chondrocytes to mature, and these chondrocytes will release IGF-1, stimulate growth. What growth hormone does on these chondrocytes is upregulate amino acid uptake and protein synthesis, chondroitin and collagen synthesis, and increases the cell size of number, and then this promotes linear growth, and these chondrocytes will release IGF-1 to have a paracrine effect on the organ these chondrocytes are contained within. Growth hormone will also stimulate metabolism by increasing plasma glucose and plasma fatty acids, but reducing plasma amino acids as organs are stimulated to take up amino acids to create proteogenesis. In the muscle, glucose uptake is reduced, but amino acid uptake is increased, and this increases protein synthesis, and so your lean body mass increases. Adipocity is reduced as lipolysis is increased to supply the energy demands for protein synthesis of the different organs. And as we can see here, the kidney, the pancreas, the intestine, the islets, parathyroid organs, skin, connective tissue, bone, heart and lungs are all stimulated to increase protein synthesis, increase nucleotide synthesis, and increase cell number. And this will then increase all these organs' size and all these organs' function, and it all comes down to the central effect of growth hormone on these organs. So when it comes to the failure of a developing individual to grow, it's called pediatric failure to thrive, and there are a number of reasons of this. And it's just characterized as the inability of the person to grow normally by accepted growth charts by the CDC. And it can be due to a large variety of organic causes: inadequate dietary intake, abnormal absorption of food, abnormal losses for the GI tract, or inborn errors of metabolism that prevent the use of your nutrients and the lack of normal growth as a result. But it can also be due to non-organic causes such as dysfunctional relationships, abuse, and things like that cause emotional deprivation, and these are thought to occur then due to endocrine dysfunction as a result of that. I showed you how growth hormone is released from the hypothalamus and the pituitary axis, and then these sort of non-organic causes that causes extreme stress then can cause a dysfunction in the release of growth hormone that then results in the failure of the individual to thrive. And so sleep deprivation or abnormal sleep patterns can then disturb this release of growth hormone leading to the pediatric failure to thrive. And this is because growth hormone exhibits a diurnal rhythm. It has a circadian release, and as this circadian rhythm is disrupted, so is the release of growth hormone. As we see here, this is the release of growth hormone. Shortly after going to bed, this is when this major spike of growth hormone happens, but then you get these pulsatile releases of growth hormone during sleep, and this then stimulates growth, and if this is disturbed, then also your growth will be disturbed. When it comes to examining the release of growth hormone in an individual, particularly in patients who fail to thrive, you would stimulate the release of growth hormone using different agents. So L-DOPA as a stimulus for growth hormone release, and arginine is amino acids that also stimulate growth hormone, and then clonidine is a alpha adrenergic, so it will stimulus, and propranolol then is a beta blocker, which will stimulate it through preventing beta adrenergy, and insulin will also stimulate growth hormone by lowering blood sugar, and hypoglycemia will then stimulate the release of growth hormone. These are some of the things that clinically are used to stimulate growth hormone, and then it'll allow you to test whether the body is able to release it, and it'll get at possibly some of the conditions that are affecting the patient's failure to thrive. Okay, so moving on from growth hormone onto thyroid hormone, it has implications in growth. The role of thyroid hormone in controlling growth is it's permissive for the effects of growth hormone and IGF on growth. It doesn't stimulate growth directly itself, but it allows growth hormone and IGF to work much more effectively, and so when you have enough thyroid hormone around, growth can occur normally. Without it, growth is retarded, and the person doesn't thrive. Fetal growth is independent of thyroid hormone, but as I noted, and I'm going to emphasize it again, thyroid hormone is absolutely vital for the development of the neuronal tissue in this perinatal period between 23 weeks of gestation and about a year after. Without it, you get irreversible neuronal damage, and if the thyroid hormone is not reintroduced, you will also get growth development problems, not just in stature but in bone development. And early in fetal development, T3 and T4 is from the mother, and another effect that thyroid hormone has is in the ossification of bone. So for normal development of the bone, you need normal levels of thyroid hormone. And this describes what thyroid hormone does to allow for this permissive effect. Basically, thyroid hormone maintains growth hormone production by stimulating the increase in receptors for growth hormone releasing hormone on the pituitary. It also has an effect on the target organs so that they're more sensitive to growth hormone, so more receptors for growth hormone on the bone and on the liver, which results in a release of IGF. And thyroid hormone also increases the number of receptors for IGF on target organs. So the presence of thyroid hormone just makes the whole system works better by increasing receptors for the different parts, for growth hormone releasing hormone, and for IGF, and therefore making those hormones more effective at their sites. And so this then reiterates what I just said, and to summarize, the lack of growth in the absence of thyroid hormone is due to a lack of effects of growth hormone. I'm going to briefly go over the control of, or the regulation of thyroid hormone release here. Again, it is the hypothalamus pituitary thyroid gland axis that is used in this situation. And so thyrotropin releasing hormone is released from the hypothalamus down onto the pituitary, where you have thyroid stimulating hormone release, and then thyroid hormone, a thyroid stimulating hormone stimulates the thyroid gland to release thyroid hormone, both T3 and T4. T4 is the hormone that's released in greater quantities, but these both feed back onto the pituitary to inhibit the release of TSH, and onto the hypothalamus to release TRH. Note that there's no short loop feedback. What this means is that TSH does not feed back to the hypothalamus or onto the pituitary to inhibit its release, and this has implications then for the production of goiters, which I'll go into in more detail after we look at the production of thyroid hormone itself. So this figure shows you how the body creates thyroid hormone in the thyroid gland, and it all starts with this sodium iodide symport, and this is where the epithelial cells of the thyroid hormone, this is the basal membrane, so here we have blood flowing past, and then in the side we have the follicular lumen, and these are the epithelial cells then that trap the iodine using this transporter, and it can concentrate iodide in the epithelial cell 30 times greater than in the blood. It's very effective at doing it, and it uses the sodium gradient that's high outside and low inside in order to facilitate this trapping of iodide. And so it relies on the sodium potassium ATPase to create this gradient, and then these transporters pull iodine in. At the same time, you have thyroglobulin made in the endoplasmic reticulum, which is lots of tyrosine end on end, and then this is transported into the Golgi, and then these both are then transported, the iodide and the thyroglobulin is passed through, iodide passes through using this pendrin transporter, and thyroglobulin through vesicles into the follicular lumen of the thyroid gland, and once in there you have thyroid peroxidase that converts iodide into iodine, oxidizes iodide into iodine, and thyroglobulin is then used as the scaffold to produce monoiodine thyroxetine and diiodine thyroxetine that is then converted into T3 and T4 while attached to this thyroglobulin structure. Then once thyroid hormone is stimulated to be released, you have hormone synthesis has already been created. You have endocytosis of thyroglobulin. This is pulled into the epithelial cell again. You have proteolysis, which cleaves the hormones, and then they are released, and then MIT and DIT are deiodinated, and the iodine is then shuffled back into the lumen of these thyroid follicles in order to create more thyroid hormone again. And then you have hormone release, and as I said before, T4 is released in greater quantities than T3. Now, the effect of thyroid stimulating hormone on the cells, the epithelial cells of the thyroid gland, is shown here. it binds to its receptor, increases cyclic AMP, increases calcium, and increases growth factors, and it has a tropic effect on these cells and on the whole of the thyroid gland. And what I mean by tropic is that it increases nucleotide synthesis and protein synthesis, and this increases cell size, cell number, and the number of follicles that form. So the whole thyroid gland begins to grow, and that's what tropic means. And you get increased trapping of iodine as a result, increased colloid synthesis and proteolysis of thyroglobulin, releasing more hormones, and you get increased glucose oxidation and NADPH generation. Essentially, TSH makes the gland work harder and grow bigger, and so it's said to have a tropic effect. And because it doesn't have this feedback effect, because TSH doesn't have a feedback loop, if there's something wrong, you don't have enough iodine, or the thyroid isn't able to release thyroid hormone, there is no feedback, and as a result you'll just get constant TSH released, and this just makes the whole thing grow. You get larger follicles, you get more and greater epithelial cells, and as a result the whole thing grows, and then with a lack of iodine you get these goiters formed. And hypothyroidism, the take-home message here for growth is that hypothyroidism in development can lead to mental retardation, stunted growth, and abnormal skeletal development. So moving on to insulin. Insulin is required during fetal growth because hypoinsulinemia causes growth defects in the fetus, so it's required for glucose uptake by the placenta. Optimal growth requires insulin, and that's because insulin is your main metabolic hormone. The role is to regulate metabolism, increase protein uptake, increase glucose uptake, increase fat uptake, and these are all the building blocks you need to grow. And so without enough insulin you get defects in your growth and a failure to thrive. But insulin is also known to stimulate osteoblasts to promote bone formation, and so it's required then for your skeletal development. Moving on then to glucocorticoids. These are released from the adrenal gland, and normal growth requires normal levels of cortisol. However, too much and it inhibits DNA synthesis and inhibits growth hormone release, and thus can inhibit normal growth. So you need a certain amount of cortisol to maintain normal growth, but beyond that it can start to inhibit it through its effects on DNA synthesis and on the release of growth hormone. Another thing that it does is that it's known to inhibit the effect of osteoblasts. Remember, osteoblasts create bone, osteoclasts degrade bone, and so by inhibiting the actions of osteoblasts, it can cause degradation of bone and osteoporosis as a result. And exogenous administration of corticoids has a potential side effect of bone demineralization. So someone who's on a course of corticosteroids might actually suffer from brittle bones. But one thing we need to point out here, because cortisol is a very important hormone that has effects all over the body, and just for your own learning, it's important to point out some of these effects. That's shown on the next slide. And so some of the things that cortisol does is that it decreases connective tissue. We talked about in the food to fuel block, it inhibits inflammatory responses. It's very important to stop wayward immune responses in times of stress. It also maintains blood pressure. by stimulating the hormone, the enzyme required for producing epinephrine, phenylethylamine transferase. It important in the maturation of the fetus. It has mineralocorticoid activity. It modulates emotional tone, maintains muscle, and decreases bone formation and increases bone resorption. And all these things you need to know about the effects of cortisol. And in the absence of cortisol, you get, it's called adrenal insufficiency. So this might happen after someone has had a course of steroids and come off it. You have weakness, hyperpigmentation of the skin, weight loss, salt craving, syncope, and hypertension. And then people who suffer from hypercortisol secretion or Cushing syndrome, they have redistribution of body fat, moon face, and abdominal fat distribution, weight gain, fatigue and weakness, hypertension due to cortisol's effect on blood pressure, menstrual irregularity as cortisol can influence the menstrual cycle, personality changes due to the effects of cortisol on the brain and your emotional state, muscle wasting because cortisol stimulates proteolysis, edema, again related to blood pressure, thinning of bones, glucose intolerance because it's diabetogenic, and the thinning of skin because of its effects on fibroblasts. And all these effects are summarized in the previous slide of the overall effects of glucocorticoids on the body. Finally, we will talk about sex hormones here, and the increased concentration of the sex hormone that occurs during puberty is responsible for your final growth spurt that results in attaining your adult posture. And the origin of these hormones, primarily the gonads, although some production occurs in the adrenal cortex, and this is important in later life as production from the gonads decreases. As I said earlier, and I'll reiterate because it's an important point, the sex hormones promote the lengthening of the long bones, but at the same time they promote the eclosure of their epiphyses, so then they halt growth. So they give you this final spurt, but then stop it by preventing any more cartilage being laid down. And it's now known that the growth of the skeleton during puberty is the result of increased estrogen in both male and females. In other words, these sex hormones travel to the location and are converted inside into estrogen, whether it's testosterone or estrogen being released by the sex organs. Testosterone is converted to estrogen via aromatase at target organs, and then they stimulate their effect. And the actual increase in height of the long bones is due to growth hormone of IGF-1, and the action of IGF-1 is stimulated by the sex hormones. In other words, at the target sites, at the organs, the sex hormones stimulate the production of receptors for IGF-1, and so during puberty, the release of IGF-1 stimulated by growth hormone elicits a greater effect on growth. So you still need growth hormone release at the time, you still need IGF-1 release, and the sex hormones make that release more potent, and so you grow faster. It's worth reviewing the release of sex hormones from the gonads, and it's controlled by, again, the hypothalamus pituitary gonadal axis. The hypothalamus releases gonadotropin releasing hormone, the pituitary then releases the gonadotropins, both luteinizing hormone and follicle stimulating hormone, and then the the hormones released, testosterone and estrogen, feed back onto the pituitary and the hypothalamus to regulate their release. And then we have the release of inhibin or activin that either inhibit or stimulate release from the pituitary. And the life cycle of the gonadotropins are shown here. On the left we have the female only, and we get a couple of spikes of gonadotropins during the early years, the FSH and LH release, and then it drops down until we get to puberty where they start to rise again, and then obviously you have the period of menses during the reproductive years, giving monthly surges and spikes of LH and FSH, and then after menopause, where you get no more estrogen released because ovulation stops, the lack of feedback makes the gonadotropins remain high. And if we compare that on the right then to the release of the gonadotropins in the male and the female, it's much more consistent, but even in the male during senescence you get a rise in FSH and LH as this feedback mechanism is reduced, because you get a lowering of testosterone released in the male, but it's just not as acute or dramatic as in the female, where there is very little estrogen being produced at all. The sex hormones have an effect on bone growth, and bone growth in adolescence is mainly comprised of modelling. Bone growth exceeds bone demineralization, even though you are still having formation of bone at one site and reabsorption at another. But then in the adult life, after puberty, the bones are in a steady state balance. You have modelling and remodelling happening at a steady state until you get to later on in life, where the sex hormones start to fall away, and this causes an imbalance. So parathyroid hormone and calcitonin usually control calcium concentration, but estrogen and testosterone act on bone to decrease the rate of both osteoclasts and osteoblasts. When there's enough sex hormone around, this is in balance. But then once estrogen falls away, the osteoclasts tend to become dominant as the osteoblasts are inhibited because of the lack of estrogen, and this then causes problems with this bone remodeling, which results in weaker bones. And so low estrogen levels allow osteoclasts to live longer, osteoblasts to live shorter, resulting in greater bone resorption and thus osteoporosis. So particularly in the aging female, although it does happen in men, post-menopausal, the bones become brittle because you get more bone decay than bone formation. And this is due to the dual mechanisms of estrogen's action. You have the classical nuclear pathway and the non-classical extracellular pathway. And basically the nuclear mechanisms decreases the rate of remodeling by acting on both osteoclasts and osteoblasts, but the extranuclear mechanisms mainly works on the osteoblasts and keeps the osteoclasts alive. And so because of this, when you don't have enough estrogen, the osteoclasts win out and you get more bone degradation, and that results in osteoporosis.